start, sir?
Okay, you can start.
1 minute. Oh. Good evening, everyone. I'm Dr. Jasmine, Senior Resident in OBGY in GMC Akola. I welcome you all in this special academic curriculum of PG Star Series and special association. Sorry, ma'am.
Please start. Please continue, better.
Sorry. And an association of Nagpur OBGY Society with the Government Medical College Akola for postgraduate student in OBGY. Today is series 16 with the topic of recurrent pregnancy loss. Now I would like to invite Dr. Sushma Deshmukh ma'am, President of Nagpur OBGY Society, for welcome now.
Thank you. A very good evening to all. It gives me celebration-like feeling to welcome you all for today's PG Star Series organized by Nagpur OBGY Society with Government Medical College Akola. Thanks, Dr. Aparna Vane. Now we are entered in December, that is in Carnival month. And today we are discussing recurrent pregnancy loss and amazing role of hysteroscopy in recurrent pregnancy loss. And as you all know, we are going to witness a mega event on hysteroscopy. Rather, it is a grand academic feast. And very important to have a starter like this, a small CME, like small webinar before the grand academic feast, which is 1 week after we are having. So now, what happens when dealing with the RPL patient? With good news, patient is happy, family is overjoyed with pregnancy, doctors are very satisfactory, all checked. But suddenly, everything vanished away. And it happens repeatedly again and again in spite of all support. And now patient is really in agony. She says, why this is going on? Why me only? Family saying, why doctor, why? And now what gynecologist should say? So Dr. Gurmeet Kaur decided to take a challenge to explore and evaluate. She is going to present a case of RPL. Now two great academicians, Dr. Savita Kamble and Dr. Anil Humne, they will help her to succeed in her mission. We know Dr. Anil Humne is a great artistic gynecologist, great poet also. So now welcome to Dr. Sarita Kamble, Dr. Anil Humle, and Dr. Gurmeet. But after evaluating many things, we know it's an inability of the uterus to hold the fetus. So we need to evaluate the mother organ, that is uterus, which is very, very important. But how? It is a hysteroscope. It just adjusts the curves of the uterus. If you see the 2.9 mm hysteroscope, it really having a feminine classification that it adjusts the curves of the uterus. So it will evaluate, treat, and cure the intrauterine problems. Basically, it is an art. I always say hysteroscopy is an art. That's an amazing, rewarding technology. And how to overcome these uterine problems? We searched hysteroscopy world. So we have searched the hysteroscopy world and found a genius hysterostar. That's the Dr. Farendra Bharadwaj. So welcome, Dr. Farendra. He will going to take us a journey of this RPL. There's a role of hysteroscopy in RPL. But we need some brilliant captains for this. And Dr. Vijay Nahata, Dr. Rohidas Chavan agreed for this carrying the warmth. So welcome Dr. Vijay Nahata and Dr. Rohidas Chavan. Dr. Jasmine is going to do a great job to all the faculties in one string. Welcome to all PG students, seniors and friends. And the pillars of this PG activity, Dr. Anuja Bhalerao, Dr. Bhakti Gurjar, Dr. Prachi Dikshit, and my secretary, Dr. Pragati Khadkar. Friends, again I announce that witness a mega event of India, which is really good, having a very talk of the India, that's the Nagpur Hysteroscopy Carnival on 15th, 16th and 17th. Please register. We are having simulator workshop, live operative workshop. It's a wonderful opportunity for all of you. We are having 4 international faculties, all IIG big faculties with us to witness on this wonderful event. And so enjoy this event also. So we'll definitely, it's a good opportunity for all PGs also to witness this event. So now enjoy this discussion of RPL. Thank you very much.
I welcome Dr. Savita Kamble, ma'am, a Senior Associate Professor and Head of Unit Department of OBGY in BJMC and SGH Pune. She has a special interest in high risk obstetric and genetics, adolescent health, and quality improvement. Her major achievements are Dr. R.H. Acharya Memorial Prize at AMOGS 2010, Special Jury Award at 45th Annual Conference Research Society, National Mentor for Lakshya Program, Master Trainer for EMOC, RTI, STI, IPAS, Deputy Secretary Research Society of BJMC, and participated as faculty in many state, national, and international conferences. And our second examiner, Dr. Anil Humne, sir, Associate Professor and Unit Chief, Department of OBGY and Gynecology in GMC Akola, GMCH Nagpur. He has a teaching experience of 25 years. He runs endoscopic unit at OBGY GMCH Nagpur. He is MUHS PG guide and examiner. He has to his credit 20 publication in both national and international journals, recognized as a collaborator in World Endometriosis Research Foundation, master trainer in helping babies breathe, training ART, GJ Hospital, Chennai, and advanced laparoscopy at KEM Hospital, Mumbai, faculty at local, regional, national, and international conferences. He has completed ICMR project as autoimmune marker for diagnosis of endometriosis, maternal near miss, and corrective measure taken at the selected tertiary care hospitals, National Registry of Pregnant Women with COVID-19, pre-COVID registry. And he has a special interest in infertility, critical obstetric and advanced gynecological laparoscopy and hysteroscopy. And he is live member of FOXY, AGOI, and IAGE. Now, I would like to welcome Dr. Gauramrit Kaur, second year PG resident of GMC Akola.
Good evening, everyone. My topic is recurrent pregnancy loss. Patient detail, name, age 25-year-old female, housewife by occupation, 12th standard, resident of Washington. Obstetric history G4A3, LMP is 6/4/2023, EDD is 30th 1/2024. She is a book case. She's giving a history of 12 weeks of amenorrhea, no fresh complaints. History of presenting illness. The patient who has a history of 20 weeks of amenorrhea came to OPD in view of previously pregnancy loss. Menstrual history. Attained menarche at 12 years of age, regular cycles, normal flow, not associated with pain or clots. Marital history. Married for 5 years, non-consanguineous marriage, no contraceptive used. Present OBS history, spontaneous conception. Pregnancy was detected in first trimester by urinary pregnancy test by 5th week of amenorrhea. No history of excessive vomiting. No history of spotting or bleeding per vagina. No history of swelling of legs, breathlessness, and no history of burning micturition. No history of pain in abdomen. No history of exposure to radiation or pathogenic drug intake. Folic acid tablets taken. Dating scan was done at 6th week and was found to be normal. Anti-scan was done at 11th week and found to be normal. History of previous pregnancies. Patient had 3 previous abortions in 2019, 2020, 2021 at 20th, 18th, and 16th period of gestation respectively. First pregnancy loss was 4 years back at 20 weeks of gestation, spontaneous conception. First trimester scan shows a good fetal cardiac activity. Pregnancy was uneventful, following which at the 20th week there was spontaneous rupture of membranes, sudden expulsion of product of conception without any pain. No history of exposure to teratogenic drug. No history of surgery for removal of placenta or bits. Placenta products and features were sent for histopathology and no abnormality were found. No history of preceding events such as fever, infection, trauma, drug intake. No history of fever, blood transfusion in post-abortal period. Second pregnancy loss 3 years back, gestational age 18 weeks at the time of miscarriage, spontaneous conception. First trimester scan showed good fetal cardiac activity. Pregnancy was uneventful, following which at the 18th week there was constant back pain and sudden expulsion at home. No history of exposure to teratogenic drug, no history of preceding events such as fever, infection, and no history of fever or blood transfusion in post-abortal period. Third pregnancy loss 2 years back at gestational age of 16 weeks. Spontaneous conception was there. First trimester scan showed good fetal cardiac activity. Pregnancy was uneventful, following which at the 16th week there was spontaneous rupture of membrane. Product had begun to expel before the patient could reach the hospital. Placental products and fetus were sent to histopathology and no abnormalities were found. No history of exposure to teratogenic drug and no history of fever, infection, trauma, drug intake. Past history. No history of swelling of legs, breathlessness. No history of gestational diabetes mellitus, preeclampsia, diabetes, thyroid, chronic kidney disease, SLE, and Epla syndrome. No history of long-term medication in the past and no history of surgeries in the past. Family history not significant. No history of diabetes, hypertension, tuberculosis, or congenital anomalies in the family. Personal history consumes mixed diet, normal bowel bladder habits, no history of smoking, drug abuse, or alcohol consumption. Journal examination. The patient is conscious, cooperative, well oriented to time and place person. Weight is 59 kg, current weight 60, before pregnancy 59 kg, after conceiving 60 kg, 1 kg weight gain, normal weight gain, BMI 23. No pallid icterus, cyanosis, scrubbing, pedal edema, or generalized lymphadenopathy. Vitals, blood pressure 120/80 in right upper limb in sitting position, pulse rate 80 per beat, and respiratory rate 13 per minute. Temperature normal. CVS S1 S2 heard, no murmurs. Respiratory examination normal, vesicular breath sounds. CNS examination, no focal neurological deficit. Examination of breast, thyroid, spine normal. Obstetric history, patient is reassured and after emptying her bladder is laid in spine position and examination is conducted. Small bulge seen in the suprapubic corresponding to 12 weeks of gestation. No scars or dilated veins seen by patient. Fundal height corresponding to 12 weeks of gestation. Summary, Mr. XYZ, 25-year-old female with obstetric code G4A3 at 12 weeks with single gestation who is booked belonging to the lower socioeconomic class, came with 12 weeks of amenorrhea with history of 3 second trimester pregnancy losses, no prior any surgery. Her vitals are normal and on OBS examination, uterus corresponding to 12 weeks of gestation. Diagnosis, 25-year-old female G4A3 with 12 weeks of amenorrhea with single gestation with history of recurrent pregnancy loss for further evaluation and management. Routine investigation will do complete hemogram, PT, APTT.
Can I speak in between?
Yeah, ma'am.
Yeah, I just wanted to ask, you have given a clinical diagnosis.
Yeah,
Okay.
ma'am.
So can you give us some clue what could be the diagnosis?
She's 25-year-old female, gravida 4, abortion 3, with 12 weeks of amenorrhea, with history of recurrent pregnancy loss for further evaluation and management.
Okay, so that is the diagnosis you have given me. I would just
Yeah.
like to ask you one question. This lady has aborted every time in the hospital, correct?
No, ma'am, once, twice,
Where has the obstetric events happened?
ma'am, twice it happened in the hospital, and second pregnancy loss was at home.
Okay, but she was booked at every time, I suppose, in your history when I was listening. So she's been registered every time.
Not with us, ma'am. She was
No,
registered
no,
with someone.
wheresoever. I'm just asking you. So she was
Yeah,
registered.
yeah,
Okay,
ma'am.
so she was registered and she was just aborting every time.
Yeah, ma'am.
Okay, and now she's come to you at 12 weeks. So from the history, can you give us some provisional diagnosis? Can you
Ma'am,
think of some provisional diagnosis?
as there is always second trimester losses, because we have seen in a history that 20th week abortion, 16th, 18th week, and then 16th week. And it gave us also a clue that second trimester losses are there and they are spontaneous and painless and expulsion of product of conception. So it can be because of like cervical incompetence, maybe the cause of this.
So you are telling cervical incompetence, but you are not sure. So because in the examination you have told us about the per abdominal. Have you done the speculum examination for this patient? Is it indicated?
Ma'am, yeah, we can do that because 12 weeks gestation, we can do per speculum examination also. But here it is
Okay.
12 weeks only. So we can do per speculum and PV4 to look at the internal os snap.
What are what are the two things which you would like to see when you are doing a speculum examination in a
Whether
pregnant state?
any leak history, and is there a bulging of membrane and dilatation?
Do you expect that at 12 weeks with cervical incompetence in your mind?
No, ma'am, that.
Okay, fine. So I just wanted to confirm that because the spectrum examination is, I think, must. Okay, so maybe Humne sir can go ahead because she was just presenting
Yes.
the case. I thought we should do a clinical discussion before
Nahin,
we
yes.
go into the management. So that's why I
Yes.
disrupted her.
So to interrupt, so clinical, once you project your clinical diagnosis, that whatever you are suspecting, strong suspicion, so you have to include that in your clinical diagnosis. So that is I think she has missed, though she is suspecting, but she has missed to write on the clinical interpretation.
Okay, you can go ahead, no problem. Don't worry, this is not exam. We are not taking your exam. This is just a presentation. Okay?
Okay. Okay. So
Yeah.
we will proceed with the
Yeah.
routine investigation. We will advise the patient complete hemogram, PT, APTT, blood glucose levels, PDRL, HIV, blood grouping, and RH typing, HBs antigen. Specific investigations will include anti-phospholipid antibodies, lupus anticoagulants, APTT, beta-2 glycoprotein, anti-cardiolipin antibody. Thrombophilia screening can also be do factor 5 return mutation, prothrombin mutation, and deficiency of protein C or S, thyroid function test, and endocervical swab for culture sensitivity, karyotyping of parents, ultrasonography, and transvaginal sonography.
Okay, now see, Gurpreet, no? Gurpreet,
Good,
am I
good,
pronouncing properly?
good,
Yeah.
Amrit.
Uh, Gur
Amrit.
Amrit. Okay. Uh, Now, just one comment about the investigations. So, as a clinician, when we see the case, okay, we would, you're at Akola Medical College,
Uh,
correct?
yes, ma'am.
You're second year resident at Akola Medical College, and the routine investigations are fine. But just go on to the next slide of specific investigations. Yeah. Now, can you please defend your specific investigations? You have given a big list, and I think, are these all available with us in our medical colleges? And are
No,
they indicated?
ma'am, we can advise the patient, but these facilities we are not available at the government setup.
Yeah. So, the point being that, see, whenever we have a provisional clinical diagnosis, okay, so if you got a provisional clinical diagnosis, so in that we can prioritize the investigations depending on your diagnosis. So if your diagnosis is cervical insufficiency, so from that point of view, if you put your investigations as your TVS USG as a first to know the cervical length, to know the condition of the internal os, whether there's funneling or is anything, okay, and then
Yes.
if you want to add on, you can add on. Okay. So I would agree definitely with the thyroid function test, maybe a endocervical. It is not endocervical swab. Remember, she's a pregnant lady, isn't it? So we don't want to disturb the cervix. Maybe you can take a vaginal swab, high vaginal swab you can take. Okay. Now, rest of the things like anti-phospholipid antibodies and anti-cardiolipid antibodies. So for that, are you suspecting her to be an APLA syndrome?
Apply is common in first trimester, but it can occur in like second
Yes.
trimester also. So
So what are the criteria to label patient as an APLA to suspect?
3 or more consecutive abortion less than 10 weeks, and one abortion more than
Okay.
10 weeks, and vascular thrombosis, and one clinical criteria. These are clinical criteria. Lab diagnosis, we can make these investigation: anti beta 2 glycoprotein, anti cardiolipin, and one clinical and one lab criteria will make a diagnosis of APLA.
Okay. So is your patient fitting into that?
No, ma'am.
So two things just I would like to suggest is that whenever we are doing a case presentation and whenever you are giving a provisional diagnosis, your investigation also should go in that manner. So it should be individualized investigations. And suppose if your patient is also fitting into the APLA, then that can come down the list, maybe to complete the list if it is giving you any suspicion. Even on examination, I did not find whether the blood pressure is high or there's any albumin or anything. Okay. So there's no mention of any maybe thrombosis or anything in your past history also. Okay. So that's why putting antiphospholipid antibody as the first specific investigation, I would, I may not be very happy on that. I would rather be very happy if you put a TVS ultrasonography and point 1 to 3 on sonography. What would you want to do? Because she's only 12 weeks and all obstetric events have happened at one is 20, 18, and 16. Am I correct? If I have
20,
taken you
2018,
properly, isn't
16,
it?
yes.
Yeah,
20.
isn't it? So there are, you can say second trimester, and she's just at the end of first trimester. Okay. So just to come back to your diagnosis of cervical insufficiency. So how are you going to diagnose this? Clinically and by investigation?
Clinically, we will look at cervical length, internal loss,
Okay.
whether internal loss is dilated or not. We'll do PV examination, and
Mhm. Are we supposed to do a PV
P,
examination or a speculum examination?
in cervical
What would be
insufficiency.
informative?
Pardon, ma'am, can you please repeat it
Can
again?
what will happen
what
if
are we
you do
supposed
the
to do?
PV? Yes, PV. What will happen if you try to do the PV examination? What can happen to her? So
Uh,
whether it is indicated or not, your patient is
no,
already a case of
PS, 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 we'll
PA.
do PS
Yes. Then
perspective examination. And
hmm,
it is like clinically, and you want to diagnose, like you can use USG also to look at the funneling of the internal loss, and
so at what gestation you would like to do the TVS sonography for abdomen or trans vaginal?
trans transvaginal sonography.
So any prerequisite is needed to do the TVS? Any prerequisite? So whether you will allow her to fill the bladder or with empty bladder,
Empty
anything like
bladder,
that?
empty bladder. We'll proceed with empty bladder for TVS, transvaginal sonography, and for transabdominal sonography, we need a full bladder.
So what you are supposed to look for, if suppose is the case,
Cervical length we'll look at, and funneling of the internal loss. And if cervical length is less than 2.5 centimeter, then it is a it will make a diagnosis of cervical insufficiency.
mhm. So how to diagnose cervical funneling?
Internal loss, diameter will be like 1.5 to 2.5 centimeter.
Internal loss is
Internal loss will be dilated.
of what?
What
Which
centimeter?
yes. How
1.5 centimeter.
1.5. You could leave apart the internals. Okay. And what about trans abdominal sonography?
2.5 centimeter internal loss dilatation.
Internal side.
Is it interloss which
So
is dilated, or you're trying to tell a cervical length?
Ma'am, cervical length is okay, but internal loss dilatation also will look at whether funneling is T shape, Y shape.
so you can make out the dilatation of the whole cervix on TVS other than internal loss. You can make out in this case she is having history of three losses. You can make out the dilatation of the even the cervix. So the internal loss, that's okay. Then the cervical dilatation. So then again, that gives you the picture of um, inevitable. Again, you are a case of previous three. So then in this case, it's very sometimes emergent to take the decision, and you have to accordingly you have to admit the patient and do the counseling. So what is the need, when to operate the patient, and so what are the circumstances. So depending on that TVS finding, you have to decide the date of if you are planning for the circular. So that is very so very important. So anything you want to do while doing TVS, anything you want to make out other than cervix.
Uh, cervical cervix. We will see the viability of the fetus also, whether the fetus is alive or not, or is there any congenital anomaly related to fetus before proceeding with
And the
the
placenta,
placenta is
the
low lying
location
or
of the
not,
placenta. Yes.
location of the placenta also. And we will look at uterine anomaly.
Mhm. So you are suspecting uterine anomaly in this case? Are you suspecting uterine anomaly? The possibility
With
is the answer is no.
possibility
So,
can be there.
can be possible.
Because
Why?
second trimester losses can be related to uterine anomalies, and cervical incompetence is one of the diagnoses, but it can be related to anomalies, uterine, like bicornate uterus, septate uterus, and
But
uterine,
you said no, it is painless,
but
spontaneous.
painless. It is painless, spontaneous expulsion,
So more of cervical
incompetence.
income. Okay, your patient now you have to once the diagnosis is over, what you have to do next?
We'll proceed with the procedure. We will decide about the operative procedure or non-operative procedure.
Hmm.
If the cervical length is if the cervical length is isolated, like less than 2.5 centimeter, we'll proceed with progesterone support only. We can give progesterone support to the female. But if it is
Hmm.
related to the recurrent pregnancy loss, cervical length is less than 2.5 centimeter, plus there is recurrent pregnancy loss, then we'll do circulars. We'll think about circulars.
So when you are planning to give her a seat, now she is 12 weeks of gestation.
Most probably best time is 16 weeks, and we can proceed after 10 weeks. We can decide, and after 10 weeks also.
So in
You
your
want to
case,
do after 10 weeks?
Best time is 14 weeks.
Yeah, what is the
so how
logic behind putting it at 10 weeks? Can you explain?
10 weeks is not a good time period, but if she is giving a history of losses, 10 week I'm not sorry.
There are cases when you can think of giving. What are the those cases when you can think of giving cervical stitch cerclage at 10?
And the bulging of the membrane may be the criteria.
Congenital anomalies
Congenital no.
like
Uh, uh,
hypoplastic cervix, unicornated uterus, where you can think of laparoscopic cervical cerclage. Okay, what about your in your case? At what gestation would like to you should have? And
14
she
each.
give history of 14.
Yeah.
Okay, so now she is 12.
Yes.
So 2 weeks to go.
Yeah.
So what to do with these 2 weeks?
In cerclage procedure,
You are sending him. You are sending her back to home.
we will give
To
her
do.
progesterone support.
Hmm.
Bed rest, we will advise her strict bed rest. And even after that, if when she complains of pain, we'll say her to sudden rush to the hospital.
By the time she will reach with the expulsion.
Do you
So
want to
depending on
keep
the
her admitted?
activity,
Yeah, we can keep her admitted.
What are the advantages of hospitalization?
We can look at the symptoms. It's pain in
They
abdomen.
are painless. No cervical insufficiency, you saying it's painless. She's not had pain any time. So how are you going to keep watch?
We'll do examination of the patient.
So it's see, there are two, three things which I would like to tell. Yes, we can do cerclage at 10 weeks in very exceptional cases when you have got abortion, same about 14 weeks or 12 weeks. Okay. But when we are doing cerclage at 10 weeks, we have to explain to the couple that most of the time anomalies are not detected in the first trimester. Okay, so that is the reason, and most common reason for the first trimester abortions is chromosomal anomalies. So when patient usually passes first trimester, they are, you can say, overall clinically ruled out. Okay, not otherwise. Okay, so that is the reason we don't put cerclage in the first trimester. But in exceptional cases, yes, we can do as Sir said. Okay, but when we are doing, we have to tell the couple that a anomaly scan is yet not done. And depending on if there is a problem, then maybe we have to go ahead as per maybe the anomaly scan. Okay, that is one thing. Now, second thing, what Sir is trying to ask you, in your case, your patient has presented at 12 weeks, isn't it? Her last abortion is at 16 weeks. So usually what the all books say that whenever the last abortion has happened, 2 weeks prior to that, we put the stitch so that that time doesn't come. But as your patient, we don't know the another important thing which I would like to tell you here is that you have to ask your patient where she's staying, how she's working, is she able to take bed rest at home, is she able to come to hospital within the time? Because most of the time, these patients usually have a penless kind of thing, and they will say back footly pani gela and I aborted. Okay, so they also don't realize that something is started inside. Okay, so that's why it will be a good thing to keep these patients admitted. Okay, and when they are admitted, what we can do is we can investigate them. That is one thing. You can be sure of the diagnosis. That is the second thing. Third thing, you can start with the medical management. Okay, so to crossover, you can give a progesterones, you can give a head low, you can give a bed rest. You have to see to it that she is not constipated. Other for no reason, she should increase the intra-abdominal pressure. Okay, that also can lead to the problems. Okay, so all these things we can take care when she's in the hospital. Okay, even at 14 weeks, when you are going to put a cerclage, even at that time, we are not going to know about the anomalies. Okay, and this all pregnancies are precious, but this being the 3 losses, you can imagine the anxiety of the women, isn't it? So a good psychological support as well is important for her. So all these things, so we have to manage patient as a whole, isn't it? Not only the cervical insufficiency, that is one part which is the major, but apart from that, all the things. Another thing, maybe at 12 weeks, you might find cervical length normal, isn't it, on sonography. So we need to have maybe 2 sonographies, maybe on, you can say two, not two exactly, a month apart actually, which can tell you the uh, trend of the cervical length, whether it is same, whether it is in, it definitely will not increase, okay, but whether it is reducing, apart from your clinical examination, clinical judgment, even this can be an objective thing for you to note down, and then you can act accordingly. Okay, definitely a placental location is also must, so as to know whether it is low lying and all, because otherwise the complications can happen. So all these things we need to think when we are trying to plan a management for this kind of patient. And it is very important to communicate at all aspects, not only with the patient, but also along with the patient, with the relatives. Okay. This is what, whatever window you have from 12 weeks ahead, that you can utilize for doing counseling and all other things. Okay.
Thank you, ma'am.
Sir can add some things.
What is the surgical line of treatment now? You have discussed now the medicinal
Cervical,
part and some socio-economically you can say. So what is the now surgical part?
cervical encirclage. We will
Hmm.
advise the patient if there is recurrent pregnancy losses with the cervical length less than 2.5 centimeter. We'll do Shirodkar. We can do Shirodkar, McDonald's, and abdominal encirclage also. Oh,
You are picking. So now we decided, yes, we have to do at 14 weeks with the cervical length of 2 centimeter and the
recurrent
suggestive of funneling and all that. So everything is decided. What basic investigation you should have. Now we have having a list of investigation as you have mentioned the list of investigation. But what should be the basic for the to poster for the cervical?
routine investigations, CBC, LFT, KFT we will do. We'll check for TLC count. We'll
So
do high vaginals,
I am not seeing any urinary here.
urine routine microscopy,
So
and
that
high
is
vaginal swab, urine culture
very
sensitivity,
important. And sugar and okay.
blood sugars,
Hmm.
thyroid function.
Okay. And electively, do you like to poster for elective hours?
Yeah, we will post her for elective hours.
Okay. So what is the priority?
HBS, antigen, HCV, HIV.
Okay.
We'll, we'll do.
So under what now the patient is posted. Okay. So what to do on the day of surgery?
We'll check by USG.
Okay.
USG. We'll do USG to check the fetal
Okay.
viability.
Okay. What next? The consent part is over. You have taken the consent about
Consent.
the. Okay. That is again very important. Next,
Check
patient is entering the OT. The patient, see, today
parts.
you are
Prepare.
operating.
We will prepare the parts.
Okay, next,
Blood arrangement.
why the blood is required in this case?
Because when we'll do circulars now at 3 o'clock and 9 o'clock position, there are uterine arteries. We should take care
Yes.
of that
Can we
location.
prevent that? Can we
So
prevent that injury?
which
Yeah, we can prevent that injury.
Which uterine arteries are there?
3 o'clock branch, cervical branch of uterine artery, 3 o'clock
Hmm.
and 9 o'clock
That is
position.
above the fornix no?
Location is
You may get a cervical branch. Okay. So that you do you think that for this reason the blood is required? I mean to arrange the blood and all that. Okay. Next, what?
RBS
That
blood sugar.
over. That's over. Now your patient is entering the OT. What you will advise her to get rid on the OT table and all that? What you
Lit, lit position,
position of the
lithotomy,
under what anesthesia? Here.
general short, general.
Stop. Okay. Anything else before?
We'll arrange a suture material,
Hmm. Same thing with the
non-absorbable
bladder. See, whenever
bladder.
you have to take the patient like short G and all that, you have to see whether her bladder is empty or not. So that is very
Police.
important. Otherwise, you may need to put the infection into the bladder. There are high chances of putting the unnecessary catheterization. So that can be avoided. Just ask her to get the bladder empty. Okay, so this is very important. And next is what?
After giving
What you are supposed to have in your trolley instrument?
speculums, non-absorbable suture. Nowadays, Marceline tape is used,
Hmm.
non-absorbable, and needle holder.
You have the anything else? What is required to hold the cervix?
Valsalm, and
Volval,
Want to use Valsalem?
no, anti-vaginal.
anti-venom retractor. Yes, these are the needed speculum, then anti-venom retractor.
Anti-vaginal body retractor.
With what with you will hold the cervix?
Anti-vaginal speculums and anti-vaginal wall retractor will not use the
But for doing
tenaculum.
circulars, you need to
Tenaculum.
hold the
It's the
cervix.
pregnant
How are
Tenaculum.
you
cervix. No?
going to hold?
Tenaculum.
It's the pregnant
Tenaculum. Have you
lunar
seen
cervix.
tenaculum? Have you seen any time tenaculum, doctor? We are dealing with the pregnant cervix where we want to do a conservative surgery so that the pregnancy is to be continued till the term, isn't it? So what are the basic principles when you want to hold the cervix, the
Not
pregnant cervix?
sponge holding forceps we can use to hold a pregnant cervix. Sorry for that.
So if it is not available, then you can use Babcock.
Babcock's.
Yes.
Rather, Babcock is the ideal instrument to hold, I would say. Okay? Babcock's is the ideal instrument to hold the cervix, that too not all three clamps. Okay? Very gently, a single clamp with the Babcock, that is the ideal way to hold the cervix. Okay, even your sponge holder is going to be little traumatic, but Babcock will be the best ideal instrument. Okay, and never utter valsalum and tenaculum. Okay, please tomorrow you go in theater and please go and see tenaculum. Okay, tenaculum is not even used for gynec services. That is only used when we are doing hysterosalpingography. Okay, or maybe when you are doing leap and all. Okay, so please go and see tenaculum. Never ever utter this word. Okay, that will be really very basic mistake if you say like that. Hmm? Another thing, you are not supposed to do penting like as you do in vaginal and all. Hmm? So you are supposed to be very gentle when you are doing penting for such a cases. The simple reason being we want to continue the pregnancy, and with any of our actions, we are not supposed to stimulate the uterus. Okay? Because one of the complications that your patient can have may be contractions later on. Okay? She may go into threatened abortion, she may go into preterm. It can happen because of our actions also. So the most important thing where we have to keep in our head is that we have to be as gentle as we can. So we have to be very gentle when we are doing even a per abdominal penting. At the same time, the betadine penting, okay, once you clean with the NS, only once you can do, not like you do in other cases. Okay, but that gentleness you have to keep always in your mind. And then you can go ahead with the procedure as such. Okay. Have you done doctor cerclage?
No, ma'am.
You must have seen an assisted. Okay, so can you tell us?
Ma'am, we will do in circulars by taking the sutures anterior lip of the cervix and posterior lip of the cervix. We will approximate with the help of non-observable suture, and we will tie the knot posteriorly in McDonald procedure.
Okay, so what are the things we have to keep in mind when we are doing the procedure as such?
We shouldn't injure the bladder. We will sometimes now in Shrodkar we will
Yes,
separate
you
the
shouldn't
urine.
injure the bladder. So you have to ask patient to be empty bladder. You have to retract if it is coming in your way. You have to look at the bladder sulcus. Okay. And then below that you'll go. When you are taking the suture, you are not supposed to enter the cervical canal. It is supposed to be only in the cervical substance. Okay. So if you go into cervical canal, there are chances you may cause iatrogenic leak. So if it's the nicely good cervix, there may not be any problem. But if it's a effaced cervix or something, then there can be difficulty. So we have to be below bladder sulcus. We have to be within cervical wall and not enter the canal. Okay. And then we take the stitches, avoiding the trauma to the vessels at 3 o'clock and 9
Nine.
o'clock. And then you can tie the knot. Now,
Posterior.
when you are tying the knot, how do you know the tightness? See, previously
By
people
doing
used to
the
put
P, uh,
no, you are not supposed to do that. That's what I'm trying to tell you. Okay. If you are doing a prophylactic cerclage, then there is no point. That means the
like
interloss is closed, isn't it? Okay, so there are different methods. If interloss is open, the membranes are seen out, then you need to do what is called as rescue cerclage, where you'll have to maybe push in the membranes. That's a totally different method. But when you are doing a prophylactic cerclage, then we expect cervix to be good. And at least these principles we have to follow. Okay. In case when you have got a patient where the membranes are bulging and all, then there are different methods which we have to follow. Isn't it? Sir can add, sir can add other things.
Okay, what are the types of circulage, oth- or rather, what are the indication other than cervical incompetency, where you can give the circulage?
multiple
Yes, yes, multiple gestation. You are right.
preterm pregnancy, threatened preterms.
History of preterm. You can say the history of preterm, previous history of preterm, two or
Along.
more preterm deliveries, and the cervix is 3 centimeter. In that case, you can, yes, prophylactic. What madam has she has given you the hint, prophylactic. One is twins, preterm. Any other?
Amputated cervix, anomalous cervix,
Any other? So nowadays, so what we are seeing, most of the patients, those who are coming from Gujarat with IVF and all that. So the traditional, they are giving a stitch, cervical stitch. So some of the center they prefer prophylactically because of the IVF pregnancy and all that. As you know, the working women today they are the percentage. I mean, they are working female populations they are increasing with the IVF. So they prefer to give prophylactic therapy. So that is one aspect. So what are the various circulage, you know?
McDonald, Shirodkar,
Mhm.
abdominal encirclage,
What should be the ideal time of giving circulage?
14
So forget about your case. Your case is a exceptional. Like she had a previous three abortions. So definitely you would like to prefer a 14, 16 weeks.
16
But
weeks.
ideally what time?
16 weeks.
16 weeks. Okay. Do you know the detail about emergency circulage? How to handle the emergency circulage?
There is bulging membrane. With the help
And
of a gas dilator, we'll just push the membrane gently inside and then we will do that rescue.
no, not with the Hegel.
With what? Hegels.
So that will rupture, na? Your your
Digital
intention to preserve the membrane. So either you have to put with the distended
police,
police catheter or with the sponge holder. You have to moist the gauze piece and put it inside while the patient with the head low position and allow to fill the bladder with more than 500 cc.
Yes.
So that will lift up the uterus and
Uterus.
you give the stitch. What complication can arise while operating? Yes, good.
injury to the vessels. One of the thing, one is the and s- misapproximate bladder injury, misapproximation,
Hmm.
not
Okay, what then at what destination you have to remove this stitch
38, 37, 36 weeks, 36, 37 weeks. If the labor
after
pain
completion?
starts, we will do before also. But if no labor pains, then we will proceed till 38 weeks.
Okay. Till that time, how to observe this patient?
We will explain to the patient that we did this procedure. If something like pain in abdomen, labor pain started, you have to rush. Otherwise, there will be complications, uterine rupture. If there is some uterine contractions, she's in labor, and in that labor, cerclage is still there.
Yes,
What
you have
is
to
the
highlight that
typical
whatever you have done.
complication?
So you have to highlight that the cervical stitch is given to this patient. So on the top of your her case paper, you have to mention. So anytime in between, suppose she visited to other gynecology, so she should know. So yes, we are dealing with a case of cervical stitch. So that is very common. You have to highlight this on the paper with a bold letter. So that is very, very important in managing practice. There are different suture methods available. What if yet your institute it prefer?
In, in.
Which suture prefer for the cervical stitch?
Proline,
Proline. And
non-observable sutures,
hmm. So now one company that has come up with the four number Mercilin, number four Mercilin. So that is easy. What we used to put that Mercilin number one to that needle, and then again make it into one number is to make it two double, make it double
Oh,
and
mm,
have a
yeah.
stitch. But nowadays the four number Mercilin is available, adhesive, adhesive, so that you can is very good. The needle is very nice because there is a hardly any there is a technical difficulty while operating while giving a cervical stitch. So that technical difficulty that is avoided because you have to circumferentially you have to take the stitch at 3 o'clock, 12 o'clock, and again at 9 and 6 o'clock. So that technical difficulty that can be avoided with the new needle and Mercedes adhesive. So I think the concern with the over, madam can add.
Yeah, that's what only one thing. As sir said, you have to mention on the paper, okay? And you have to inform the patient that whenever she starts getting pain, she has to come immediately to the hospital. Very typical complication, one which happens with the stitch and when patient gets is the bucket handle tear rather than a rupture. Okay, and these are really very difficult and they can cause lot of hemorrhage. Okay, and difficult to manage also. So all these things we need to tell to the patient and tell them to come to the hospital immediately. Okay, what can be other complications with the stitch? Sometimes it becomes goes inside. It is very difficult to remove. Have you seen such
clear,
cases? Sometimes they burrow
yes,
inside.
yes.
Okay, then what should we do then? If it is burrowed inside,
So recently one patient I have seen, she was operated at some other hospital, and after 4 weeks or so, she visited to my place, and what she told me that something thread-like structure is the
coming out.
protruding. Then
Uh,
then then I did the PS, and yes, it was thread. So with that add to my knowledge. So with the process of involution of the uterus, so that knot becomes a significant. You can
remove.
uh, it is obvious that you can cut the knot and you can remove easily. So that is also the one aspect I have faced recently.
Yeah. Most of the time, people forget to remove when they are putting her for the LSCS. That too, when they
Uh,
are doing a elective LSCS, especially in all IVF cases, it has to be kept in mind that they have to remove the stitch. Okay, if it
yeah.
is a elective LSCS, as sir said, most of the time consultant also forgets. Okay, so that has to be kept in mind. If you are doing elective LSCS, that may not cause any trauma, but then we have to remove it. If it is difficult, so when cervix reforms, it becomes easy to remove, as I said. Okay, so that also is another problem which we are seeing nowadays. So that is another added complication which you can enlist as a complication of a osteotomy as such. Okay. Yes, I think we are overshooting the time,
We are
sir.
yes, yes.
Yeah. Yeah, I think
Because
we
no
are
one
over.
is interfering, na? The MOC is not interfering. That's why.
Yeah, that's all.
Thank you, ma'am. I'm sorry, sir.
Yeah, yeah.
And now we'll like to proceed toward our second session, that is Pearl of Wisdom, with the topic of role of hysteroscopy in recurrent pregnancy loss. And I will like to welcome our honorable chairpersons, Dr. Vijay Hatha sir, Director of Gynec Endoscopic Surgery at Mahatma Gandhi Medical College and Hospital, Jaipur. Uh, he is he did her MS from SP Medical College Bikaner and USG in Gynec and Obstetric from Wadia Medical Maternity Hospital Mumbai, Royal Free Hospital London UK with Adam Magos, and hysteroscopy Sparne Hospital Netherlands with K. Wam Wamtikers and Mercy Hospital for Women and Melbourne, Australia with Peter Meher at St. George Hospital, Sydney, Australia with Alan Lamb. He is a project director at Marwari Maternity Hospital, Guwahati and consultant at Pratiksha Hospital, Guwahati. He is organizing secretary of National Conference of IAGE from 1919 to 2008 and founder editor of GOGS Bulletin, founder secretary of NEISAR, founder chairperson of IAGE chapter of Rajasthan, and conducted several live endoscopic surgery workshop and paper in international publication, conducting regular training program in hysteroscopy and laparoscopy. And second,
Jasmine, 1 minute. Before all we'll have one group photograph. Savita ma'am,
yes, sir.
Yes, yes,
otherwise
yes,
everybody
ma'am.
will go.
I just wanted to tell that only that I would be
Just,
leaving the session.
just no, I can understand. That's why I was trying to stop her. Just wait,
Okay.
because one session is over. Just let everyone be there. Please
Yes,
open your windows.
yes,
And
yes. So I would just
and
like to be
thank you
sorry
for
for
it was
that.
a
I
very
am
nice interaction.
happy. Yeah,
And you came
yeah.
here. Welcome again for this wonderful discussion. And really, it was very
Thank you
nice.
so much. Thank you so much.
Yeah, and
So I
I
would
also
just
did
like
very
beg
well.
your pardon and would leave the session. We have got some
Just
other
yeah, I can
yeah,
understand. That's why we have a one
yeah,
photograph, ma'am. Please, Ruchi,
yeah, yeah.
please open the windows. All I think faculties are here now. Can you just stop sharing so that we can have a good photograph? Jasmine,
Yes, ma'am. Yes, ma'am.
only 1 minute. 1 minute,
Yes, ma'am.
because
Yes,
everybody is
ma'am.
leaving. That's why. Just please stop sharing your PPT. Then we can have a one photograph.
Yes, ma'am. One minute. And yes, ma'am.
You are not. Yeah.
Yes.
Ruchir? Yes, yes. Ruchir, please.
Yes, madam. Done.
Done? Okay. Thank you all faculties. Okay. Jasmine, please go
Thank
ahead.
you.
Thank
Thank you
you.
very much.
Thank you so much,
Thanks for
Kamble madam and
gracing this
Anil
webinar.
sir.
Yeah.
Thank you so much. Thank you.
Shall I start?
Yeah, yeah. You can start now.
Yes, ma'am.
Just make it full screen.
Yes, ma'am. It's okay. No?
Yes.
And now I would like to welcome our second chairperson, Dr. Rohidas Chauhan sir, MBBS MBBS MD from KM Mumbai, Professor and HOD of OBGYN Department at GIMS Government Medical College, Akola. He has a special interest in management of high-risk pregnancy and NDVH ultrasonography. Founder secretary of Yavatmal Obstetrics, and the president of IOGS Yavatmal, president of IMA AMS, ex-superintendent at Shri Vasantrao Nayak Government Medical College, Yavatmal, UG and PG teacher and examiner at MUHS. Last 25 years experience of UG and PG teaching and many publication in national and international publications. I welcome sir.
Thank you.
Welcome, sir.
Thank you.
Welcome, Dr. Vijay Nahata.
Yeah, madam, thank
Welcome,
you.
sir. Welcome, sir.
And I really appreciate Dr. Yasmin to read out my CV thoroughly. Someone has taken trouble to read it thoroughly first time.
It was my pleasure, sir.
And to introduce Farinder is a real pleasure. He is I can describe him as a very good skills in hysteroscopy and a born teacher. I call him a congenital teacher. Hello. Some people are born with the teaching, and you will definitely now you will see when he delivers his talk, and you will see his real capabilities.
Thank you, sir. Thank you so much, sir. So, without wasting much time, first of all, I would like to thank the Nagpur OBGY Society. Am I audible? Amrit?
Yes, yes.
Yes,
Yes.
fine. So, Nagpur OBGY Society, Sushma ma'am and Pragati madam for giving me this opportunity. It's a wonderful platform where we can interact with the upcoming gynecologists. And of course, Kamble madam and Anil sir has given them a wonderful insight. I can see how patiently they are teaching the students and guiding them in a proper way so that they can understand the evaluation and not only investigation based but clinically oriented future gynecologists which we need again, so many. So let me start the talk. The job which is given to me by Dr. Rishma ma'am is to discuss role of hysteroscopy in recurrent pregnancy loss. So, dear friends, one sec. So, dear friends, recurrent pregnancy loss is, which we have already discussed in this case. This was a case of recurrent second trimester abortion, and the diagnosis has come to be an incompetent OS. And I was surprised that patient had a 3 abortion and none of the she didn't have any ultrasound report of previous abortion during her in between interval, that which is suggestive of any etiology, and no workup was done for an incompetent OS, which can really help us in managing it in a better way. As in this particular case, interval cerclage has a role, rather than going with a pregnant cerclage. Pregnant cerclage has its own advantages and disadvantages. So of course that is a different thing. Now we'll start the role of hysteroscopy. Now hysteroscopy is required in cases of RPL. In fact, it is required for all uterine surgeries. Nowadays, we call people who are more into this surgery is called as intrauterine surgeons. So let me start with the topic: is pregnancy loss is something defined as spontaneous loss of pregnancy before they achieve the period of viability. Various guidelines, way back we used to read consecutive losses of 3 or more like this, but now the latest Speroff says, and in fact the guidelines also says that consider the diagnosis of recurrent pregnancy loss when there are loss of 2 or more pregnancies. Ectopic and molar pregnancy should not be included in the definition, and implantation failure is also excluded. But yes, pregnancy loss of spontaneous conception and ART should be included in the definition of recurrent pregnancy loss. Types are primary and secondary. Patient had a previous pregnancy primary, never had a previous pregnancy secondary or recurrent pregnancy loss, and never had a pregnancy primary. causes of RPL, as Dr. Amrut has already discussed, various causes: chromosomal, structural, autoimmune, endocrine. But these are theoretical things. As a postgraduate, we need to understand all these causes and put it into our history taking and try to find out that our which category the patient is fitting. So let me start the structural abnormalities in which there are two categories. One, from the treatment point of view, of course, we have divided them in a correctable and a congenital one. So even in congenital, the septum is one of the correctable one, and various unicornuate, bicornuate, adelphic uterus are the various anomalies. Correctable one or intrauterine pathologies are polyps, myomas, and intrauterine adhesions. Guidelines, what the guideline says that yes, of course, all the women with RPL should have an assessment of uterine anomaly, or in short, I can say a detailed ultrasound needs to be done. Not going into the details, but yes, nowadays transvaginal ultrasound in a case of RPL, whatever I'm talking now onwards is pertaining to the RPL. Transvaginal ultrasound is one of the important aspect, and preferably it is to be done with 3D ultrasound, and especially if you're suspecting some Mullerian anomaly, 3D is must. And if it is not available in, as we can say, it's not available in most of the part, you can consider going with MRI with a good radiologist who can evaluate your uterine anomalies. So now let me come with the topic. Of course, a patient with a endometrial polyp, usually these polyps do not cause recurrent pregnancy loss. Yes, of course, but this is intrauterine pathologies. The guidelines of polyp of more than 1 centimeter needs to be removed from the uterus, and here comes the role of your hysteroscopy. So because if you want to take out a small polyp from the uterus, you cannot do a laparotomy, you cannot do a laparoscopy. The only way is to go in the natural passage and enter into the endometrial cavity and complete the job. So this is what I'm just keeping my talk relevant to the postgraduate so that they can understand that these are the ways a polyp can be removed. So this is the way a small hysteroscope, whichever is available, usually we call them as 2.9 millimeter scopes with a 5 mm operating sheet. Nowadays, we don't use a diagnostic sheet word or a, no, we have got a operating sheets, which has got an inbuilt channel of 5 French channel. 1 mm is 3 French. So this is how you go. You cut the polyp, you try to cut this polyp from its base, and then grab it with a grasper, take it out and send it for biopsy. So in a patient with a recurrent pregnancy loss, if you're finding some endometrial polyp, consider polypectomy. Sometimes if a patient is giving you a diagnosis of ultrasound is giving you a diagnosis of thickened endometrium, also consider hysteroscopy in such patients, because you might be dealing with some polyps, and which can be easily diagnosed and treated with the help of hysteroscope. Here again the same principle are follows, using a 5 French operating instrument. Here we are using a hysteroscopic scissor. You cut, go near to the base, and these are technical things which you can easily learn in your colleges, in your nearby hospitals. Many training programs, various societies are conducting, especially for postgraduate, to make them comfortable and understand the science of hysteroscopy. Again, in Nagpur, we are organizing a wonderful event, and again, a dedicated session for the postgraduate to understand. Another important aspect of intrauterine pathologies which can lead to recurrent pregnancy losses is myoma, especially myoma which are distorting the cavities. As far as the guidelines are concerned, they do not say that they are the cause of recurrent pregnancy loss. But yes, if some big myomas are there which are distorting the cavity, especially submucosal myomas type 0, type 1, you should consider hysteroscopic myomectomy as a modality of the treatment in cases of recurrent pregnancy losses. Nowadays, considering the operability, we are moving towards a more better classification rather than FIGO. This is what we call as step W classification or LASMAR classification. For a postgraduate, they need to understand that previously we were looking for just cavity protrusion. Nowadays, we are looking for size, topography, extension, and penetration. And this is how we decide the operability. A very important investigation, and I've kept a video that even in curriculum, the ultrasonographic training should be done for residents, especially the transvaginal ultrasonography. We expect a gynecologist to do a transvaginal ultrasound and learn. So it's very important. So identifying the cervical canal, endometrial lining, and then defining the pathologies by their own or going to the radiology department to understand is very important. If you cannot diagnose or if there are multiple myomas, you can anytime take the help of MRI, which is also a modality. If 2D ultrasound, 3D ultrasound are not able to give you a proper diagnosis, you can really consider. Sorry. Am I audible? The voice is coming properly. Is it okay?
Yes, sir.
Yeah, fine. And the videos are playing?
Yes, sir.
Fine, ma'am.
Yes, everything is fine. No problem.
Thank you, ma'am. So, meanwhile, if the video plays, so MRI is again important. You should not rely on the printed report, whatever you are getting. You should at least make a habit of sitting with your radiologist friend, sit with them in the console and try to identify which type of myoma you are dealing, and they can really help you out in describing such condition. So fine, this video is not playing, which is of MRI. Now here is the surgical video of, it's a big submucosal fibroids, and these are the fibroids which can really hamper or affect the ongoing pregnancy, or can affect the. But usually they are the cause of severe menorrhagia and can lead to patient in heavy menstrual bleeding and anemia. So if for these type of myomas, hysteroscopic myomectomy is one of the treatment of choice. Here is a detailed video of another myoma. See, this is a tricky situation. This was a case of a pregnancy loss and having a submucosal myoma, which is of type 2. Type 2 means less than 50% into the cavity. Let me just keep it myself very simple. So, but whenever you are going with a fluid in the cavity, you're creating some pressure, and with the pressure, you may not be able to see the fibroid. In this particular case, this was a mid-cycle, there was a thickened endometrium. So I've done a suction and evacuation to remove the excessive endometrium and then proceeded with the surgery. Now here, with the help of mapping on ultrasound as well as on MRI, you know that the myoma is lying on this posterior aspect in the mid-cavity portion. You are cutting the capsule of a myoma. We know that myomas are single cell tumor, leiomyomas, and they are surrounded by compressed tissue. So these are technical things. You can use a hydrodissection way, you can use prostadine, you can use, injection which can contract the uterus and make the myoma bulge more into the cavity so that you can really remove them completely. And once the myoma, let me show you. So once the myoma is more inside and you know the exact location, and then you can use resectoscope. So in previous surgery, polypectomy, I've shown you mechanical instrument, which is scissor, by which you can cut the polyp. You can cut the myomas, small myomas with the scissor as well. But if you want to do a bigger myoma, use a resectoscope, which are electrosurgical instrument, which goes in the uterine cavity, and you can cut. I don't say that myomectomy should be done by the beginners. It's for the expert hysteroscopic myomectomy, but as in the beginning, they should understand of a patient of a submucosal myoma, hysteroscopic myomectomy is the option and patient can be treated. Next is intrauterine. Again, in the acquired problems, polyp, myomas, and intrauterine adhesion is one of the important aspect which can lead to infertility, or the thin endometrium can lead to recurrent abortions. The various pathologies are described is basically the damage of the basal layer of the endometrium by whatever causes, DNC or metroplasty or some surgery, endometritis or infection. Classifications are given which describe the intrauterine adhesions depending upon the extent of the cavities involved, type of adhesion, and the menstrual pattern which the patients are having, various other classification. And then symptomatology, if we go with intrauterine, they say that previously, whatever the menstrual pattern is there, now they are experiencing less amount of bleeding. This is what the complaint, and clinically, which we call it as a hypomenorrhea. They can be amenorrhea, they can be a cryptomenorrhea, and various presentation you can have. Bimanual examination usually do not really reveal anything if unless until there is an infection. But yes, ultrasonography, serial ultrasound, pattern of endometrium is really help them in diagnosis. If somebody has an HSG, will give you some spilling defect like picture or distorted anatomy. But ultrasound is of real value. It can give you a idea of irregular endometrial lining not growing properly along with this clinical history, and there are certain fluid collection in the endometrial cavity. You can see in many IVF patients, they say that we are consistently finding after uterine surgeries, we are finding some fluid in the cavity, and 3D ultrasound is of real help. Nowadays, I urge all of you to understand the ultrasound and learn the ultrasound in your post-graduation time. We are also organizing a event dedicated on ultrasound in gynec and obstetric patient at our institution, Mahatma Gandhi, in the month of February 2024. So I welcome all of you to be a part of this and understand how the ultrasound is helping you in your day-to-day practice, and can help you in diagnosing better than some of your radiological colleagues. So this is how, in this case, you can see there are some adhesion you can suspect, there are fluid pockets, and then you can plan the surgeries. In this case, I'll be showing you nowadays we all hysteroscopic surgeons are not dilating the cervix. We are entering without dilating. In fact, nowadays we are not even touching the patient. There's no touch technique. And many of us are operating or doing certain procedure in our clinics. So here after entering the cavity, we can see only one part of our ostia, which is the right ostia. And the left ostia is not visible. It's a good case where we can negotiate the internal loss. In difficult cases, especially where there's internal loss fibrous or dense fibrosis or grade 4 Asherman's, you may land up in false passages as well. Various complications you can have while operating the Asherman cases is false passages, perforation. Rarely you can have infection nowadays, and bleeding is not that common. So here again, we are using this mechanical Caesar and creating the cavity. And this art of hysteroscopy needs to be learned. By way back we have heard all the dictum that my hysteroscope is my stethoscope, and it stands true for all of us as a gynecologist. Because laparoscopy is done by many people, urosurgeons, gynecologists, a general surgeon, but hysteroscopy is something which is your stream. The way we say that vaginal surgery is to be done by a gynecologist, hysteroscopy also to be done by our fraternity people. And this is how you're creating the cavity. You're coming back, orienting yourself, going back again, and then creating a triangular shaped cavity. Now, what is important after creating the cavity, the next problem is re-adhesion formation. So for that, you should use intrauterine devices, especially I would say triangular balloons or Foley's catheter can help them keep these separated wall apart, along with your medical therapy in the form of estrogen can really gives you a good lining endometrium. Nowadays, we all are using stem cells as well. We really don't know what is the future of all these procedures. Yes, of course, we are also into the process of using stem cells into the uterine cavity, and PRP are also used by many people to manage the thin endometrium, but these are the options. So keeping them apart and a relook hysteroscopy along with the medical treatment is something which is standard. you can do in cases of intrauterine adhesions. And that's another case where HSG was done and showing some defect, filling defect. You can see, and then once the diagnosis is there, hysteroscopy is the only choice to manage such cases. So moving to these are the theoretical part, which I've already discussed with you when I was describing the surgical videos. So a reoccurrence is something which is important, and you can use all these devices and reanalysis. Now come back to the congenital anomalies. Yes, various congenital anomaly. We know that the classifications are available, ASHRAE and ASRM, which classify the all levels of anomalies, but especially if you can say the correctable anomalies, which can really be corrected with the help of hysteroscopy, is septate uterus. And so of course, we do a metroplasty in bicoordinate uterus, but the guidelines also do not say. Very few of us are doing metroplasty in bicoordinate uterus unification surgeries, where in cases of recurrent pregnancy loss, if the pregnancy is not able to survive, a patient is really not having a single child. But septate uterus is something which all of us are doing, and you should do. And probably in your case, whatever the clinical diagnosis has come up, incompetent os, all the congenital anomalies are bound to have internal os problems, and one must evaluate the patient of recurrent pregnancy loss of second trimester to have any intrauterine congenital anomalies, especially the septum, or it can be a unicoordinate uterus, or it can be something else. So theoretically, it's a result from incomplete reabsorption. There are fusion defect and there are reabsorption defect. So clinical significance, of course, it can lead to preterm deliveries, spontaneous abortion, malpresentation, and problem at the time of delivery. But cervical incompetence is something which is also associated with these type of congenital anomalies. Diagnosis of these anomalies can be done with the help of ultrasound, and HSG way back we used to do and understand used to various angle of acute angle and obtuse angle, but nowadays 3D ultrasound is the one which can give you exact diagnosis of having a septate uterus or a bicoordinate uterus, and in case of any doubt, you can anytime consider MRI. Now this is for the clinician and for us also. Whenever we are learning our ultrasound, please learn the ultrasound and try to draw the diagram of your findings onto one page. It will help a clinician to plan the surgery to make the patient understand about this problem. So whatever you are finding, you are running at the time of doing ultrasound, you are doing it in real time, and you are writing it on a paper. But if you can draw all these things in a paper, it can help clinician. So here, what we want is the width of the septum, the depth of the septum, and the fundal indentation. And then you can plan the surgeries of septum by mechanical way with the help of hysteroscopic scissor or electrosurgical way. But what is the preference is, yes, for the beginners, we say go with a smaller septum and we use the scissors. Once you are comfortable, then you can use a resectoscope, and nowadays 5 French needles are also available, which can help you out. So here I'm just showing you the surgery of one of the septate uterus. Again, negotiating the cervical canal, no touch technique, and whatever view you are getting is of cavity, and there you can appreciate that the two cavities, two osteas, right and left ostia, and there is a big septum. Hysteroscopically, you cannot diagnose whether it is a bicoordinate uterus or a septate uterus. It has to be done pre-operatively, and once you are sure, then do a hysteroscopy. I'm not recommending, and in fact, the guidelines are not recommending to do a laparoscopy unnecessarily to confirm your diagnosis of septate and bicoordinate. It can be easily done with the help of imaging. Yes, of course, for infertility evaluation, if you are putting a laparoscope, and for tubal patencies, it's acceptable. And you should always take a consent of doing a laparoscopy at the time of hysteroscopy in case of any advertent event. or you can any complications. Here I'm using a 5 French needle to cut this septum, and in my next video I'll be showing you this was a case of infertility where uh, uh, pelvic evaluation was also required. So you have put on a laparoscope as well. You assess the tubes, then you do a hysteroscopy. Which is suggestive of septate uterus. Now, before cutting the septum, I would recommend and I would suggest to do a tubal patency test rather than after cutting the septum. And sorry. So the message which I wanted to give you whenever you are planning a tubal patency test along with along with the septum resection, do a thorough evaluation, identify the any structural problem, identify the extent of the septum, and then in each cavity you can just push a die and once your telescope is there, you can just push a die from the hysteroscope and you can confirm the patency with the help of laparoscope and then proceed with your septal resection. Various other anomalies like T-shaped uterus and lateral metroplasties are also there, but none of the guidelines are recommending to do any surgery for all these things. But of course, in patient with having a very small cavity and having a history of recurrent abortion, one can consider giving a hormonal therapy along with that. Hysteroscopic metroplasty is one of the option, or cavity widening one can do. Even this can be done in cases of unicornate uterus as well. So that's a very small cavity and a different fundal to cervical ratio. You can see our ostia and fundus is very small. The help of again scissor, you can do this cavity widening procedures or metroplasty. So a hysteroscopic evaluation in cases of recurrent pregnancy loss is something important, along with your clinical evaluation of ruling out cervical incompetence and various other hormonal and autoimmune causes. And ultrasonographic and hysteroscopic holds a very important position in management of patient with such recurrent pregnancy loss. So I wish all of us can become big intrauterine surgeons, and I just keep my talk, here only, I just switch off. And I'm open for any question, and if anything you want to ask me, I can go into the details of all these things, all these procedures. Thank you so much.
Hello.
It was very fantastic and very nice, Dr. Farendra.
Thank you, ma'am.
I learned that you are a very good speaker. Now I witnessed it also.
Thank you so much.
I
No,
think
I
all
have
PGs
to,
are very lucky to have such a good, wonderful faculty.
I have to tailor this talk to postgraduates so that what I can do in this half an hour just to give them an insight, and I can really make them understand that what is the future of course,
Yes.
we need to learn everything. Now the domain has increased. You need to understand the genetic fetal medicine aspect, also genetical aspect, also various guidelines have come. So they need to learn a lot.
Yes, sir.
Chairperson, please.
Dr. Sushma,
Yes.
I think in the beginning, my introduction for Friender was apt, that he is a very good speaker and
Yeah,
good
you
teacher.
told.
One to just we are associates. So just to complete the talk, there is a one thing which has that which is coming up is the histo tissue removal.
Yes, HRT system.
That is, but in India still we are we are novice because of the price and many other factors.
Yes.
But as a this thing, because what our learning is with the resectoscope and all these things. So later on we may acquire. And one more important for the PG students and any clinician, that pre-op evaluation and the clinical paramount. I will just like to quote one case. Me and Friender, we are with running this endoscopy unit here in medical college. This is one of the college which is having a separate endoscopy unit. So we get lot of referral cases. We got one referral for the septum. It was diagnosed on ultrasound, 3D, and MRI also. But the person who was operating, he could not, while doing the surgery, he could not find that septum. He could find only one cavity. Then that came to us, and this thing somehow we found that there was a vaginal septum also. So that fellow previously he just entered in the one cavity, and something clinical evaluation was missing. So he missed that vaginal septum because he was just taking the help of only imaging. So that clinical, we should not, whatever the gadgets we have, we should not forget the clinical evaluation. And again, this is a very good thing. I'm very happy that we are coming on to Nagpur, that the city,
Yes.
and we'll be meeting you in person on this 15th. Yeah. So it
I'll
will
be
be
Yeah,
missing
really, we are
most.
very much eager to welcome you all. It is
Yeah.
going to be a very big event. Already one faculty arrived in Mumbai. Dr.
Oh,
Maria
wonderful.
Francini is there in Mumbai.
Yeah. Okay.
And today Gubini will be there.
Wonderful.
He'll be landing Gubini with his wife.
We are very excited to be there.
Yeah, I am also very much excited to meet you all also. It's a very good gathering for hysteroscopists around this in country.
Best wishes,
So
ma'am.
I
It will
again
be a big
request
show.
everyone.
Yes.
Yeah, it's not like, but it's a good academics and everything. That's I always love. And it's a good discussion only on hysteroscopy because I love hysteroscopy too much.
Yes.
So I think everyone should be there. I request all PG students. It's a very good opportunity for all of you to witness all such a very good proceedings and all live operative workshop. Then the simulator. The all faculties, Dr. Maria Francini is going to teach on simulator. He told me I want to teach all the PGs and all the newcomers. So everyone can get the advantage of all these things. Thank you very much.
Thank you. So, few words from Rohidas, sir.
Yes, Dr. Rohidas, sir, please.
Yes, I'm very happy to listen your lecture on hysteroscopy and lectures also. I'm like interactive. Both PGs are from my college, and they are very good. And in Akola Medical College, we have modular operation theater, 3D and everything, and many workshops successfully we have organized. I am very happy to be a professor here at the Akola GMC. And
Sir, please be
thank
there
you,
for
Sushma Reshmi
carnival,
madam,
sir.
that you included me. Yeah,
Sir, please be a part
yeah,
of carnival.
definitely, definitely. Yeah, definitely, madam. But because of this adhication, no, it is a little bit difficult to leave the place. That
I
is
can
the
understand.
one hurdle. We'll see it, madam. Yeah. Thank you, madam. Thank you very much.
Okay.
Okay.
Thank you, madam. Thank you so much. Thank you, Nata, sir. Thank you, Amrit and
Thank you, sir.
Thank you,
Thank you,
sir.
sir. Thank you, sir.
thank you so much.
It was really very good. Jasmine,
Just
you did very well.
yes.
Thank you.
And clinically also presented very well better. Very nice
Thank you.
discussion.
Thank you.
Yeah.
Now
Okay,
I'd like
ma'am.
to call Dr. Pragati Karade ma'am for vote of thanks.
Okay.
I think is she there? Dr. Bhakti,
Dr.
please check, or
Pragati
you can.
Khadkar ma'am.
Dr. Bhakti, please
Yes.
check.
Yeah, I
Otherwise, you
think
take her.
I think Pragati Khadkar madam is not there. So on her behalf, I would like to propose a vote of thanks. At the outset, let me begin by thanking Sushma Deshmukh madam. This is her concept of starting this particular postgraduate teaching program, and we are very happy to share that this was the 16th series of the year, and we plan to continue this throughout the year. We have 7 to 8 very interesting activities lined up. So I request you all to stay tuned to this also. So I thank her. I thank all the faculty, our examiners, Dr. Anil Humne sir, Dr. Savita ma'am, our speaker, our star speaker for the day, Dr. Bharadwaj sir. They have really given their great inputs. And they have really helped to add knowledge to the postgraduate students. I am sure they will be benefited a lot. The presenter for the day, Dr. Guramrit Kaur, she has also done a very good job. I'm sure she has learnt a lot today, and she will be a more confident person when she faces her exam. Uh, our MOC, Dr. Jasmine. Dr. Jasmine has done a good job. She has pitched in at the last moment, but she did a good job. So thank you, Jasmine. Then I thank Corona people. They are our technical support. Without their support, our programs are not possible. And lastly, I want to thank all the PG students who are.
Bhakti, Dr. Vijay Nahata and Dr. Rohidas Chavan.
Yes, of course. Our chairpersons,
Yeah.
Dr. Chavan sir and Dr. Nahata sir, they have really given their great inputs to the talk. And last but not the least, our PG students for whom this program is being run. So thank you everyone for joining. Thank you very much.
Thank you, ma'am. It was a pleasure.
Sushma,
Thank you.
Thank you.
hello, Dr. Sushma.
Yes, 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 sir.
I will just like to say that 16, we can add a sweet 16. Hello.
Okay.
So,
Okay.
thank you.
Okay.
Thank
Yeah.
you.